Well, welcome everyone to this our July George Eliot board. We have the AGM later, but delighted to have so many members of the public with us. We've spent a long meeting already this morning talking about the need for us to continue to develop our open and honest and straightforward culture. Really good work going on behind the scenes, led by our newly appointed Managing Director, Catherine Free. On behalf of all of the board, Catherine, we're delighted you were successful in the very comprehensive process to choose a new Managing Director, and we are absolutely certain you will build on the legacy of David Elchingham and take George Eliot to an even better place. A number of things to discuss on today's board, so we'll get going. First of all, just in terms of apologies for absence, Umar Zaman, our non-executive director, is away, so he sends apologies. Any new declarations of interest? Please raise a digital hand. Can't see any digital hands raised. So move then on to the minutes of the meeting held on the 6th of June. If there are any points of accuracy regarding those minutes, could you please raise a digital hand? Can't see any digital hands raised, so I'll take them as accurate and duly sign them. Thank you, Sarah and Vanessa. We'll therefore move on to the action points arising, which are on page 23 of our pack. The first was regarding the timings of the finance and performance meetings. That has been sorted. Thank you, Sarah. The second was regarding HAC to provide benchmark data on the number of FIR requests. That's been done. Thank you, HAC. The next one was also for HAC to look at whether the trust received frequent FIR requests from the same group of individuals and feedback to the chairman, and that was done. Thank you, HAC. Then for NAJ to consider monitoring weekend discharges by ward to help identify any potential areas where discharges may slow down over the weekend. That's still ongoing. Is that correct, NAJ?
No, that is complete, Russell.
Okay, thank you. And what was the conclusion there, NAJ?
So we do have the data. It is shared and it's shared through bronze and silver, and our site teams do use that data to monitor wards to monitor the discharge from wards. And if we find that there has been a dip over a few days, to actually go and support the wards and see, what's going on.
Okay, super, thank you. And then the next one is for you, Naj, to share learning from the LDAR structured judgment review with counterparts of Swift and Wye Valley. Can you just remind us what LDAR is, Naj, and then give us the update?
Yes, it relates to learning disability patients admitted with learning disabilities. And this was a case that was presented regarding a patient who had learning disability. He was admitted under the surgical team and sadly, underwent some complications and died. And it was the learning from that, how we should be involving learning disability and autism nurse specialists early on in the process. And there were quite a few other learning about support for patients when they come in. So we've got our adult safeguarding. There's some funding for relatives and carers to come in and support the patient, and in decision making as well. So it was quite a lot of learning from it. And the ask was to share it with colleagues over at Swift and Wye Valley, we've sent the SJR and the findings of the report over to those sites.
Very clear. Thank you, Naj. Glenn, did you want to come in on that?
Yeah, if I could, Russell, please. This came up, Naj, at yesterday's integrated care system executive meeting, talked about particularly the issue about patients with mental health learning disability diagnosis on the waiting list. And could we just check that we have that flag on the waiting list and that we are prioritising those patients as part of the kind of waiting times journey, because strong evidence shows that we should be doing so.
Okay, will do.
Okay, come back to us on that, Naj, if you can. That'd be good. Thank you. Then Natalie, to provide update on AHP's offering the trust. You did that, Natalie. Thank you. I think Frouty is a particularly good example, but thank you very much. And then Jenny, to consider using a more positive and appropriate title for the Warwickshire North Levelling Up report. Where have we got to with that, Jenny?
Yeah, so we've liaised with the Purpose Coalition in terms of that we can actually amend the title should we wish to do so. Interestingly, we presented at a recent Warwickshire North Health and Wellbeing Board, and the CEO of the boroughs asked us to consider consider the implications of changing the report, because he felt it was quite useful to have it related to levelling up. So we just need to be aware of that and then come to some agreement about how we title it, but also link it back to levelling up so that it's clear to that agenda. So that's the latest update.
Okay, it was about giving it a more positive title, but we'll come back to that. Thank you, Jenny. And then Glenn discussed the best approach for monitoring and reporting on top-level national priorities. That's been flagged up in the group dashboard, is it, Glenn?
Yeah, so next time you see group dashboard, and we'll try and get this followed into individual trust dashboards, those very important national indicators will be flagged.
Okay, super, thank you. And the next one was, I think, Anil, we've found a way through this, was to plant a tree for babies born and for people who passed away in our care. I think that's been actioned, hasn't it, Anil?
That's correct. The donation-based tree planting scheme will be formally launched tomorrow to coincide with the 75th birthday, Chair. Okay,
super, thank you. Not my 75th birthday, I'd like to point out to members of the public, but the NHS's 75th birthday, which, as Anil said, is being celebrated tomorrow. Are there any actions arising that you feel I have missed? Okay, we'll move on then into Glenn's report. Glenn, how are you seeing things?
Thank you, Russell. I'll just pull out a few things from my report, just some highlights. So firstly, Further Faster, which is the outpatient improvement initiative that I referred to previous month, is well and truly started, and there's been a series of specialty level workshops for the participating trusts with the National Girth team, which will help us to make further progress. I mean, we'll see it later. The performance of George Eliot on elective recovery is really strong. We also need to just watch our long wait data, because of our strong position, we will be offering mutual aid to other systems, and when those patients arrive, they're obviously long waiters, so it skews it a little bit. National UEC recovery plan, a lot of work going on this at the moment. There's going to be a universal offer, so that's for all trusts, opposed to those trusts that have been highlighted as needing additional assistance. So got a copy of that before it's released, and we're sharing that in order just to make sure that we've done everything that we can ahead of winter. But again, there's a really positive position on that, which I'll mention in a moment. Provider Collaborative Innovators, an update on how that's going, trying to help us to move all of the trusts in the group into that lead provider, host provider mode. And being part of the national programme is helping us to remove some of the barriers to that, which is good. BAPIO, British Association of Physicians of Indian Origin. I talk about the launch that we had a few weeks ago and the MOU that we signed with them to help us to work to improve our quality diversity approach as an organisation. They'll be doing a survey of some of our BAME doctors, which will give us some more insights into improvements that we can make. I then refer to the CQC inspection of urgent emergency care services. That will be published later this week. I'm not allowed to talk about it now, but anyone watching, if you look out for that, I'm sure it will be a really interesting report, and we'll talk about it more next time. National Volunteering Task Force, I included Appendix 1, a national report that's just been produced following the work of the task force, which has been led by Ruth May and Sir Tom Hughes-Hallett. And actually, Sir Tom this week has agreed he's going to come and talk to one of our board development sessions soon about volunteering, which is great. It's a great report, and it's also great to see George Eliot featuring in it. So if you turn to page 11, you'll see a bit more about what George Eliot there. Also, Wye Valley get a mention within that too. Then there is the 75th birthday of the NHS, which we've already talked about, and it happens to be just in a few weeks' time my 40th anniversary in the NHS. So as I get older and weaker, the NHS gets older and stronger. But it's a good opportunity this week to have a look at, to reflect on the improvements that we've seen across the NHS. Sometimes there's a bit of nostalgia about the way things used to be, but there's huge improvements that we can talk about, particularly the way that we've moved locally to a more ambulatory model to delivering care to patients, so that they're home first and receiving care in their own home. King's Fund report I referenced there, which is an interesting read, and I also allude to the fact that we were expecting a birthday present of a NHS workforce plan, and we received that birthday present on Friday. So next board meeting we'll talk a little bit more about the component parts of that. There's some positive announcements in there. There's a need for clarity, I think it's fair to say, on the way that some of that's been funded, but it's a workforce plan that's been very much looked forward to for the last year or so, so it's good to see that in place. We then go into an update on medicine and some of the work that's been going on around SDEC, same-day emergency care, and also it notes the improvements to Pathway 1, so the community recovery service, which was the integration frontrunner work for Warwickshire. Yes, it's the summer, so we'll see how it's going in the winter, but it's really good to see flow improvements as a result of the changes that we put in place there, and that work is being shared elsewhere in the NHS. Also to note that the Wye Valley team visited George Eliot recently to look at UEC improvements and are taking some of those back into their practice there. And then there's an update on some of the work of our resourcing services teams, which obviously resonates to the workforce plan, some really good work to improve our recruitment processes and our time to hire, and our equality diversity approach as well. So lots of things going on. Happy to take any questions.
Thank you very much, Glenn. Any questions or perspectives to Glenn? Julie?
Thanks very much, Russell. Thanks, Glenn. Really good report as always. Just a couple of questions, comments. On further, faster, from a patient perspective, 52 weeks by March 25 still might not seem very ambitious. And I think it's just really important to understand the context and how we sit within that. But secondly, also very good is what's happened in urgent and emergency care. But I just wondered if we could just elaborate on what volunteers do within that area and how they might be able to do more.
Yeah, two great points. So, I mean, firstly, the 52-week maximum is a maximum wait. Actually, the milestone for the end of this year is to have no patients more than 65 weeks. And we expect to be able to deliver that. And we already are delivering maximum wait for many specialties. But across the NHS, there are one or two that are more challenged. But we generally are in a position where we will be able to help other parts of the NHS. I mean, one of the significant improvements for us have been the changes that we made to ENT services because we were seeing some longer waits there, and that new service is delivering shorter waits for our local patients. So we will continue to drive to have the lowest possible waiting times for our patients, but within the mix of the waiting list, there's obviously clinical prioritization as well as those patients being seen in date order. Our volunteers and the work that's referred to in that national report have been really helping us with those patients that have been on our waiting list, waiting longer than we'd like to make sure that firstly they know what's happening to them and they're reassured that we know they're waiting, but also to help them to wait well, to help them to look after themselves, and if necessary escalate any issues to us that might result in us deciding to treat them more rapidly if there are any concerns. So our volunteers have been making calls to those patients following clinical protocols, and that's been a brilliant service which has been recognised nationally. And I think that's a model that we should continue, not just for this period of elective recovery, but to ensure that any patient waiting at George Eliot for anything knows exactly where they are and who they can contact and how to look after themselves.
Thank you, Glenn. We are very blessed, and I know we have a number of our League of Friends on the call today. We are very blessed with our volunteers. There are no other questions. I'll move on and segue. And Glenn mentioned the fact that we'd had a visit from Wye Valley Trust ED team as part of the foundation group. The next thing on the agenda is a proposal to expand the foundation group. Glenn, over to you.
Yeah, thank you, Russell. And this morning, actually, at workshop, it reminded me of another example of how, working as a group, we've been sharing best practice. And the paediatric services at George Eliot, we undertook a review 2 or 3 years ago now, which was led by Jane Clark, who's a paediatrician at Wye Valley, and it kind of demonstrates how organisations like ours can benefit of being part of a kind of wider family. I know the NHS is a family, but within the group we're even closer than that. So we developed this group model. George Eliot joined it last, so it started with South Warwickshire and Wye Valley, and then George Eliot came along. And we benefited from it, but also Wye Valley and South Warwickshire benefited from George Eliot being part of it. So about 18 months ago, Worcester Acute Hospitals NHS Trust joined us as an associate member. And so we've got to know them a little bit over that period. They've been attending our group's strategy meetings. But an opportunity has arisen due to a change in their chief executive for them to consider the opportunity to join us as a full member. They're an organisation that has some challenges, but also an organisation that has lots of great services that I'm sure we can learn from. So we outlined this previously. The process so far has been that this has gone to the Worcester Acute Board last month, and they've now formally approached us that they would like to join the group. This paper sets out the rationale for that, which includes a number of issues. I mean, one of the driving forces for this actually is a desire for NHS Trust to collaborate more. We now have a duty to collaborate, but I think when we choose those collaborations, I think it's important that there are organisations that can share and learn from each other. So Worcester Acute has a setup of district general hospitals very similar to the district general hospitals that are already in the group. They don't have community services, but George Eliot don't. George Eliot collaborate with South Warwickshire around community services. So the range of services is very similar. And through moving this forward, which hopefully all 3 trusts, existing trusts in the group, will be considering and approving this week in their board meetings, it will bring us to a bigger scale. So we'll move from an organisation that's just below $1 billion turnover to a group that's just over $1.5 billion turnover. That will give us some opportunities to look at procurement, but also to look at management capacity and sharing. It will bring with it more burden for myself and Russell as chair, because the model is that we share chair and chief executive across the group. But in order to compensate for that, we've developed the managing director role. And I'm delighted that Catherine is now substantively appointed as managing director at George Eliot. And also the vice chair role is important moving forward to add kind of strength to our leadership model. So I think whilst that will take away a bit of my capacity, I think it also opens up more opportunity to share, more opportunity to have scale, and also for all those trusts which are now geographically connected, if we approve this, for us to look at our things like our tertiary relationships and to look at the resilience of some of our clinical workforce solutions. So I think there's there's far more upsides than downsides of this. So, but I'm happy to take any questions, Russell.
Thanks, Glenn. So the recommendation is for approval of this. We have discussed it privately before. Any questions or perspectives from colleagues? Julie?
Thanks very much. We have discussed it before, and I'm very supportive of, personally, as I'm sure others are, of the proposal, and the benefits are very clear. For those people that are watching, listening to this meeting, however, I just wanted, I suppose, to ask Catherine if the executive, her and her executive team have considered any risks and discussed any risks around joining of a fourth part of the group, whether there are any additions to the risk register that we need to add that would help give assurance to those listening about the services within North Warwickshire.
Thanks, Julie. So no, I don't think anything specific needs to go on the risk register. I think we feel as an executive team that we have benefited from being a member of the foundation group. We've had the experience of Glenn and Russell, who are not new to this game, but also, so that gives you a degree of stability and protection. It's allowed us to develop services for the population of North Warwickshire, and our focus has been on that without worrying about merging with another organisation or anything of that nature. But I think for us, we've seen a lot of benefit in terms of some of the learning we've been able to get from others, the strength and support we get from a close working relationship with other colleagues in across the foundation group that exists. And I think so we're looking forward to an opportunity to gain another partner where we can learn from them and also be in a strong position in order to help share some of our learning from our improvement journey. So I don't think we see threats, I think we see opportunities.
Thank you, Catherine. And any other questions or perspectives from colleagues? I think this is an exciting new chapter for the foundation group, an important new chapter. Worcester Acute is a very large trust compared to the George Eliot, but as Catherine said, I'm absolutely confident not only can them fully joining the foundation group benefit the citizens of Worcestershire, but it will also over time lead to benefits for us in Warwickshire North. So if you're not happy to approve, could you please raise a digital hand? Duly approved, thank you. So we'll move on then to the sustainability quarterly report. Sean, thank you for joining us. Jenny, do you want to introduce this or is it straight over to Sean?
No, I'll introduce it, and Sean, thank you for joining us. And can ask it any technical questions, I will put his way. In terms of the report, I will take it as read. This report, as you know, is a synthesis of the work that's going on across our 9 focus areas, which make up our green plan and support delivery of our decarbonisation programme. So a couple of highlights I did want to just pull out of the report. Firstly, the fact that we've actually managed to purchase our electronic vehicle which is supporting some of the work and reducing mileage. So that's really good to see. We've got a number of things in the report that indicate our clinical areas that are making progress in the sustainability area, including our making endoscopy, if I can say it, greener initiative. I also wanted to just pull through the fact that we put through a SALEX bid, which is a pre-bid around some low carbon skills funding. Unfortunately, we have recently just received confirmation that we haven't been successful in that, and that is an update to the report which was submitted before we had that information back. I hope those people that have come to site have seen the No-Mo flower area that our volunteers supported us to sow the seeds for, and is starting to take shape. So I hope people can appreciate that as that that develops. And then particularly I wanted to indicate the growth in our number of champions, and we've now moved from 2, which we had originally, through to 19 now, which is great in terms of the commitment from the volunteers, and the champions, and that's great to have them on board. And they're already involved in a number of projects, and they're the one that they'll be doing coming forward is particularly around printing, so that will be a really good opportunity for their engagement, and thank you for them to come forward to support us. And finally, we've got a number of initiatives for our communications work, which you'll see detailed in the report, and a number of campaigns that we've been involved in, for example, such as the Bike Week, etc. And we continue to link those to the awareness days. Finally, I would just like to say thank you to Susie, that's been a real champion of our pieces of work, working alongside Sean to support our focus area leads, who is moving on to pastures new. But we will be continuing to work as a team with the support of Sean and others to take forward the programme of work, so there will be continuity. Happy to take any questions, and obviously Sean will also support with any answers to anything that is specific that you wanted to pick up.
Thank you, Jenny. Questions and perspectives. Glenn.
Yeah, thank you, Jenny. And thank you, Sean, for your work on this. I mean, as you say in the report, this is another example of how, by working together across the group, we've shared some of the solutions to this. The Salix Public Sector Decarbonisation Scheme opportunity in Q3 is a big one. So I think being ready to put in a bid for that, because that's a potentially a much bigger scale opportunity, and again, Wye Valley and Swift have got some learning from that, but that could really be a game changer for us to be able to implement some of the things we want to implement. So just flagging that for everyone's attention.
Right, thank you. And I know Councillor Clondico's on the call with us. The work on solar panels is in hand, because that's an opportunity as well. Okay, if there are no other questions or perspectives, I'll thank Sean for your hard work. Please take our thanks back to all of your team, Sean. And it's very important the work you're doing for the future of our citizens, and please keep it all going at pace. And we'll move on to the quality section of our board. And the first up is a report on safe nursing and midwifery staffing. And Lorraine's joined us as well. Natalie, are you going to handle this, or Lorraine?
So I'm going to take the Safer Nursing and Midwifery AHP paper and the Acuity paper, and then Lorraine will undertake the midwifery paper, if that's okay. So I'll take the first paper as read, and thank you, Chair, for the opportunity to draw to the board's attention. So the things I wanted to pull out were that we have seen a slight reduction in our vacancies, which is always good news to see, and that we're actively recruiting and retaining month on month. And there is a programme in place looking at both international and domestic recruitment. And this has resulted in a slight improvement in the care hours per patient day, as you would expect to see, and that will continue to improve, particularly when we come into the months of September and October, because we know on our recruitment trajectory, they're going to be the months where the majority of our registered nurses particularly join the organisation and or pass their international exams to be part of the register. So we're looking forward very much to that. A continual increased capacity and demand has resulted in extra beds remaining open despite it being the summer months, and this is at a cost pressure to the organisation. But we are managing and trying to reduce particularly our temporary staffing bill with our recruitment and retention, but also ensuring that we have a week-on-week review of shifts that are required and that shifts that are put out to our NHSP partners. Safety and patient care remain our highest priority, and through daily staff redeployment and our escalation processes through our senior nursing team, I'm really pleased to say that our red flag incidents are low, and those that are reported have not resulted in any harm to patients, and no incidents have been reported as such. Retention is a big part of our recruitment and retention drive, and it is a part of work undertaken by the ICS through the Project 1000, and we have included within this report for this time round a section on what we're doing in the George Eliot with regards to retention, and this will be a feature that will be updated going forward so that we can really pay particular attention to this, as well as you'll note in the report and from the question from Rosie last month, we're strengthening our AHP section, and I'm really pleased to say on that note that we have seen active recruitment of pharmacists, which is a national problem, and we have had a 50% reduction in our vacancy rate there, which is really great going. So happy to take any questions on anything further within the report.
Great, thank you, Natalie. And when we come to talk about activity in a moment with Catherine, we are doing very well on elective recovery, but agency costs are a real challenge. Questions and perspectives? Julie?
Thanks very much. Thanks, Natalie. I think the retention and AHP sections really add to the report. Just a couple of things. Have you begun to think at all, it's probably too early, Glenn said this, about how the workforce plan and the planning within that might impact on how we present this report, is the first one. And secondly, we haven't discussed here before, to my memory, might be that I'm not recalling very well, about the vacancies in radiology. And I wondered if you could, if it was possible to just talk about that, the potential impacts on diagnostics.
So yes, the workforce plan, we are looking through that and seeing exactly what the changes would be, Julie, and I just need to really just take that in, absorb that, so that we can make sure that we do represent it. So I haven't had any thoughts on that as yet. With regards to the radiology piece, as mentioned within there, they're one of the main areas. However, we are looking at that diagnostics all the time, and the rota is there to ensure that we do not lose our patients, we do not have any delays, etc. And the active recruitment plan through our AHPs and radiology and through our urgent and emergency care directorate are really publicising those and going forward. But it is something we're keeping a very close eye on to make sure that we don't lose that diagnostic trial.
Okay, thank you. Catherine's posting pictures of wildflowers outside Lewis House in the chat box. Glenn?
Yeah, thanks. It's great to see the retention role, and it's also good to see within that the intention to improve our understanding of exit interviews, particularly keen to make sure that we don't lose people because of a lack of flexibility linked to our big move about being a very, very flexible employer. The other bit within the retention role, can I just check, Natalie, is there a proactive itchy feet clinic type approach to that? So are we talking to people who might be thinking about leaving to see what we can do to encourage them to stay?
Very much so. And I think we had our first stay conversation, I think the meeting was today. So rather than focusing on the reasons why people leave, what we want to do is focus on why are we staying and really enhancing that stay message, rather than we need the information. It's absolutely important to get that information, but would much rather capture and give people the opportunities to develop, to look at those pathways, to be able to have those conversations before they put in an application or want to leave somewhere else. So yes, Glenn, it is part of that as well. And as I said, it's part of the ICS project going forward. What can we learn from each other? What are UHCW, what are SWIFT doing? What is CWPT doing? But there is a real drive and a lead from the George Eliot on this. So yes.
Okay, super, thank you. Keep up the good work, but we do need to get that agency bill down, and we'll come back to that under the confidential section. So we'll move on to the report on acuity and dependency reviews. Over to you, Natalie.
So I'll be very quick on this one. Twice a year, we produce a report with regards to the acuity and dependency and the establishment reviews. And this is part of the National Quality Board requirement and recognises best practice to do so. So this is our halfway report that just sets out any areas that may be lower or higher in establishment with regards to the Safer Nursing Care tool, which is the methodology used. But the Safer Nursing Care tool is not a singular methodology. You undertake the professional judgment as well as looking at quality outcome measures. So this has all been undertaken. And after triangulation, I won't go through the report in fine detail, it is there, but I'm happy to answer any questions. The recommendation from the corporate and the senior nursing team is that when it comes to the budget setting round this year, so in November time, October, November time, there are 2 wards that we would recommend we need to take further look at their establishment, and they are Bob Jakin and Elizabeth, and that's because of the acuity and dependency on those 2 wards. And then there are other ideas and thoughts within the paper, but from a corporate nursing team, we will do that in a phased representation. And they're looking at the supervisory time that our band 7s have so that they can provide the clinical support and the leadership of the wards, and also looking at our actual uplift in itself, and have we got enough uplift within the budgets to be undertaking our development, our study time, etc. But they will, as I say, will be later in the year in the main report that will come to board in about December, January time.
Thank you, Natalie. Look forward to that. But in terms of this interim report, any questions or perspectives? Okay, thank you, Natalie, and can you thank everyone involved in the production of that? So we move on then to the maternity assurance update. Lorraine, lovely to see you. How are you seeing things?
Thank you, Chair. I'll take the board report as read and just bring some highlights from the world of maternity and neonates. So in month, we had 64 Datex incidents reported. We had no maternal or neonatal death, and we had no stillbirths. Our rolling stillbirth rate is 1.4 per 1,000 births, which is way below the national average of 4.2. We did declare 1 serious incident, and this was related to the sad stillbirth that we had in the previous month. And when we did our detailed review, we identified some learning around the administration for aspirin. So we did a very detailed action plan, which the ICB were very happy with, and actually closed that down straight away and said they were happy with our actions and didn't need to do an RCA. So we continue with that learning and supporting for staff and family. Our midwife to birth ratio is really good in month. It was 1 to 26, and all our women received 1-to-1 care. We continue with our prompt training and getting those training figures up to where they need to be, and our mandatory and statutory training have also improved in month. CNST Year 5 was released on the 31st of May, so we've started our action to look at each safety action to make sure we're aware of what the updates are. They do make it more difficult year on year to make sure that you're meeting your objectives, and we've identified leads for each of those work streams. And Save My Baby's Life version 3 was also released, and they've added an extra element into that. So even though we were compliant in 3 out of 5 and 88% overall, they've now added an extra element for us to review. We've also considered to continue to look at our Ockenden compliance, and that's improving month to month, and we have no red actions there, which is really pleasing to see. As Natalie said, our vacancy rates in maternity are really good at George Eliot, and we are better than the national average. And actually, when we look at our trajectory for October, we will have no vacancies, but we know month on month things change, but it's really pleasing to see. We are developing our workforce and retention team, and we also have itchy feet conversations, but we've also incorporated into that not just about leaving, but actually staff who want to look at development and going for promotion, and have those conversations with that team as well. And that's also supported by our PMAs. Our theatre work and refurbishment is on track, and the theatre's starting to look really good. And we've also started the refurbishment of Drayton Ward this week, which is really pleasing to see. And League of Friends work is also, cafe work is also progressing, and staff and the NVP have been helping support with a poll about what we're going to call the cafe. So that's really exciting for staff. So just again, the other thing that's always on our mind is that we're still waiting for CQC inspection, but we continue to prep as we would every day to make sure that our services are best if anybody visits us. So happy to take any questions.
Thank you, Lorraine. Very comprehensive. Any questions or perspectives to Lorraine? Simone.
Thank you, Lorraine. Now that you're making such great strides in bringing us such good reports and really wrapping strong governance around maternity services, would it be possible to start to see some medical staffing data in the reports? You know, often some of these reports are about relationships between the different professional groups, and we don't routinely see medical staffing. So is that possible?
Absolutely, and actually that's really paramount in the safety action for workforce. It's around that. So actually our next reports will be having some data around medical workforce and neonatals and paediatrics as well, because actually that feeds into that work stream as well. So absolutely.
Thank you.
And any other questions or perspectives? Just two things from me. Just first of all, we've delivered 170 babies in May, and best wishes to all of those families coping with sleepless nights, but a summer of hopefully much joy of bringing a new blessed baby into the world. The second thing, Natalie, is, sorry, Lorraine, I know under my work as a maternity safety champion elsewhere in the group, that there is a very high proportion of mothers who are on antidepressants whilst pregnant, which causes all sorts of issues. Can you find a way of briefing us on that? Because I do think that's a population health issue, which we need to sort of have a higher profile on, so that we can help those young families rather than at its simplest in a state of some distress as a baby approaches, how we can as a system help ensure that it's a period of great joy rather than of great worry. Thank you.
Absolutely. Yeah, I was just going to say that's one of the big themes within the 3-year delivery plan. So as a system and across the foundation group, we are looking at how we ensure we've got adequate provision for our women and families who may be suffering at certain times in their pregnancy.
Yeah, no, great. Thank you, Lorraine. And please pass on our thanks to all of the team. We'll move then on to the integrated performance report for May. We're 2 months down the line. Catherine, do you want to give us your overview, please?
I will do. Thanks, Russell. So the report covers the data from May. Occupancy remained high in May and higher than we forecasted at the start of the year. So as I reported last month, we continued to have super surge capacity open, so extra beds that we wouldn't have normally have open. They were open in April, and that continued into May with extra beds open on Mary Seacole, which is one of our wards, Katrina ward, which we closed for 12 days in the month of May. 9 days were closed in the previous month, so a slight improvement, but not where we wanted to be. And Romola ward was still open. So we continue to report 100% bed occupancy, which obviously makes everything else quite difficult. Activity was also higher than anticipated in May. In fact, we had the highest number of ED attendances in May compared since December, and the highest number of emergency admissions in the past 12 months. So despite it being a warmer month, the activity levels were higher than we had forecast at the beginning of the year. Despite that, we continued to see improvements in the 4-hour standard, and that improved from 75.2% last month to 77.7%. So not where we want it to be, but definitely moving in the right direction. And our ambulance handover delays remained low, and we continue to maintain high numbers of patients accessing our same-day emergency services. So I think to achieve those levels of performance improvements, despite the high levels of demand and the continued challenge around bed occupancy, are commendable. And I would like to thank the teams for their continued efforts and improvement in that area. Elective recovery continues to deliver ahead of national targets, with no patients waiting 78 weeks or more. And I told you last month that the national aim, and Glenn referenced it in his introduction, is to have no patients waiting for 65 weeks by the end of the financial year next April. And I told you last month that we were aiming to treat all patients waiting over 65 weeks by the end of June. And I can report that that has been delivered. So we have no patients in the organisation waiting for 65 weeks or more. Furthermore, we saw a small decrease in the number of patients waiting over 52 weeks. And that's important because we had been seeing that number increase. And alongside that, there was a reduction in patients waiting for treatment on our waiting list of around 500. And the RTT metric, which measures people waiting for referral to the standard of being treated within 18 weeks, also saw a small improvement in the month to 68.2. So these are important steps in our ambition to treat patients in a timely fashion and compare very favourably against the national picture. And we continue to provide mutual aid to other centres to treat patients who have been waiting a longer time, and where we are able to help shorten that time to treatment, we are doing that for others. As I reported last month, cancer is an area where we are not meeting the national standards, and there is rightly a lot of focus in that area. The faster diagnosis standard in April was 54%, and the national target 75%. As I told you last month, we aim to hit that standard in July or August, and to give the board some assurance, we continue to work towards this. And in June, the unvalidated position is over 68%, which demonstrates an improving picture for an exceptionally important group of patients. So turning now to our people metrics, Glenn's talked already about the good work going on in the people development team and the recruitment team. But staff sickness remains higher than our target, as does our staff turnover rate. And whilst it's pleasing to see that the vacancy rate is slowly falling, we know that there's more to do in this area, and to ensure that the staff that we do recruit work in an environment where they feel supported and valued. As board members know, we spent a lot of time this morning looking at the needs of our staff and how we can ensure that the experience of working at George Eliot is one of the best in the country. Our staff survey tells us there's room for improvement in that area, and we have to be realistic. This is not something we can quickly change, but it is absolutely fundamental to our ability to excel at patient care. And I think you could all take assurance from the detailed discussion we had this morning that this work is one of our most important priorities in the organisation. So how do all of these numbers affect our financial position? Well, the board knows that we've set ourselves a challenging and ambitious target around cost and productivity improvement in order to reach a break-even position by the end of the year. And whilst this is not going to be easy to deliver, we remain absolutely committed to doing so. You'll recall that the two main drivers of hitting that target is our reduction in our temporary staffing costs and increasing our elective activity, delivering around 118% of the activity we delivered in 2019-20. The higher levels of staff sickness, which is unusual for the summer, in conjunction with the higher level of emergency activity, have resulted in a higher temporary pay spend than forecast. And consequently, we are reporting a month 2 position, which shows a deficit of 2.7 million, adverse variance to a plan of 1.1 million at this time. Looking forward, there's a risk around the ability to reduce temporary spend in line with the plan, so at the speed that we need to do that. But our focus is on this and delivering the actions we need to rectify this at the pace we need to deliver the full target for the year. In terms of delivery around the elective activity, we are meeting the required level of activity in the month of June, and that can give us confidence as a board that we will be able to maintain that through the coming year. There's no doubt that industrial action this month will provide a challenge, but that should be seen in the context of the national picture affecting the whole of the NHS. and we will continue to focus on the delivery of the financial plan with corrective actions to improve the position this year. Finally, on quality, the mortality rate measured by SHIMI remains in the expected range. HSMR remains an outlier, but has fallen for this month for the first time since autumn 22. And whilst that is not indicative of a sustained change, it is pleasing to see that moving in the right direction. The Trust did report a never event in May where a patient received a wrong site in local anaesthetic injection. And whilst no harm occurred to that patient, that should not have happened. And the learning has been undertaken and shared at the Trust Serious Incident Group, and the action plan for that will be shared with the Quality Assurance Committee. And lastly, we are expecting, as Glenn has said, the publication of the CQC report into our emergency department later in the week. And whilst we can't talk about this until Friday, we are very much looking forward to sharing the findings of the inspection with our staff and then with the wider public at the next board. Thanks, Russell.
Don't worry, smile at the end. Catherine speaks 1,000 words. Questions, perspectives to Catherine or any board colleagues on the Integrated Performance Report? I think it is just worth emphasising the point you mentioned, Catherine, which is the doctors' strikes are immensely unhelpful in terms of our ability to drive through the waiting list volume. It is the biggest risk we face, I think, at the moment. So we would hope for a speedy resolution to this ongoing uncertainty, which does not help our citizens in the short run. Okay, team, if there are no questions from colleagues, I'll move on then to the Capital Q1 report. Hack, how are we doing?
Thank you, Chip. So I think the good news is that we're making a significant capital investment this year to replace medical equipment, improve our estate and right-size our bed capacity. So I'll just draw out some of the key elements of that. So we've secured a bigger share of the ICB's operational capital than our fair share this year, which addresses some of the previous years where we haven't received our fair share. But there's still more to go on that. So we're still pushing for the future years to get some more capital to ensure that cumulatively over the last few years, we do receive our fair share. The really big news is the £15 million investment in the 2 new wards. And later this month, we will start seeing those being delivered on site. We've also got the completion of phase 2 of the Community Diagnostic Centre, which is coming along at pace. So there's another couple of £1 million in this financial year for that. Aside from those kind of really big investments, we have, I think, finally managed to set aside some capital to refurbish the administrative floors of the maternity building to make sure that we've got good environment for our colleagues and that it's appropriate for agile working and for use for virtual clinics as well. So there's that's long overdue, really. I think we have focused on the patient areas, but I think there is long overdue that we do some work on refurbishing some of the non-clinical spaces as well. We've also got £1.5 million set aside with a capital programme for the extension to the mortuary, but there's a piece of work going on across the broader Coventry and Warwickshire system, looking at how much mortuary capacity is required, and so that might mean that that work isn't completed in time for us to spend this money this year. But also the result of that review might be that the investment is required elsewhere. In either case, we will go back to Trust Management Board to agree alternative use for that funding. So we have got a priority list of projects to do. So it will get used one way or the other, but it's just to say it might not get spent on the mortuary in this financial year. So in terms of actual expenditure, where we are slightly behind plan, but we know we will catch up, and because the 2 new wards are ahead of schedule, so we will spend money ahead of schedule. And the other thing is we are working with the directorates to make sure that the money that we've set aside for investment in equipment, that money is spent as soon as possible, so that patients can get the benefits sooner rather than later from that investment. So I'll leave it there and take any comments or questions on that.
Thank you very much, Hack. Questions or perspectives, Glenn?
Hack, I was going to ask about whether there's any potential delivery risk on the 2 new wards, but I think at the end there you talked about the fact that they're ahead of schedule. I think the construction methodology we've chosen, where they're being built off-site and conveyed onto site, does that mean that you're confident that they'll be delivered as a Christmas present to the trust?
Yeah, so I think the plan, so they're ahead of schedule, and the plan is that we would be opening before Christmas, and we're on schedule to do that, and that then gives us that additional capacity for winter, so it'll be just in time for that.
Great, thank you. Any other questions or perspectives? Just a point of clarification for me then, please, Hack. When you talk about fair shares allocation, when it comes to capital, given that some of our system partners have big PFIs, does the estimate of capital fair share allocation take account of partners who have a PFI?
So effectively the PFI is maintained as part of the PFI contract, so it does take into account that they don't need to spend a lot of money on the PFI themselves from the capital allocations. So it does take that into account.
Okay, thank you very much, Hack. Okay, we'll move on then to the Board Assurance Framework Q1 report, the high and extreme risks only. Catherine?
Thank you, Russell. So this is a big document, but that's because we're closing down the year-end BAF from 22-23 and opening the 23-24 BAF. You will notice that these have been aligned against the Trust strategic pillars and our annual objectives, and you will see that there are the actions in there that will mitigate any risks against delivery of that. The BAF has been through QAC, and I think Anil has done his review from the finance and performance side. The one thing I'd say, if I was being super reflective, would be that the one on sustainability needs a bit more work, because we've put 2040 in there, which is when we've got to achieve our net zero. But I think it would be good to show the specific actions around that we're going to do this year. Otherwise, I'd be happy to take any comments from anybody.
Thank you, Catherine. Any questions or perspectives? Fully agree with the point on sustainability, particularly given the work we were hearing Sean and team have been doing earlier. Okay, thank you. We'll duly note that, therefore, and then we'll move on to the corporate risk register for Q1. Natalie, over to you.
Thank you. So as you just said, Russell, this is quarter 1 for our corporate risks. They're just the high and the extreme risks, and these have had oversight through the Executive Risk Committee. We have 2 extreme risks within the organisation, and both of those have been subject to reports within the board today. They are our inability to recruit to key vacancies and our failure to reduce bed occupancy, both of which sit at 20. We have 20 further high risks, and they are included within the report for people to have a look to see what they are. But there is also just to report that we have had 1 corporate risk that has been closed, and another corporate risk that was closed but then reopened, and that's in maternity due to, as Lorraine said, CNST now being year 5. So our previous risk was with regards to the previous year. So that's been shut down. It will go through the directorate governance and come back onto the risk register. But happy to take any questions.
Thank you very much, Natalie. Any questions to Natalie? Julie?
Thanks, Russell. It's really in relation to this report, but also BAF. I might be wrong. I'm looking at Hack when I say this, but I don't think risk management is falling within the internal audit plan for the next year. Hack will remind me. I just wondered, just in terms of an independent review of the process, and just that overview around the BAF and risk management, whether it would be useful to go to audit committee during the course of the year, because ordinarily you would have external validation around the process from internal audit, and I just thought it might be useful to go to audit. Okay, thanks, Julie. Can I ask Hack you to take that away and discuss it with Simon as chair of audit? That would be great. And any other questions or perspectives? And it's interesting for me, the biggest risk we've got at the moment, as I said, is industrial action if that worsens. And I know that's in the corporate risk register rated as amber. Okay, team, we'll move on then to the medical education annual report. Delighted that Louise has joined us, doing some fantastic work. But Naj, are you going to introduce this?
Yeah, please. And you've used the word fantastic work by the medical education team, and the report highlights a lot of the really, positive work that they've carried out this year or in the past year. And again, a background of an increased amount of responsibilities, which I'm sure Louise is going to touch on. So without further ado, with your permission, Chair, I'll hand over to Louise. She's going to pick up, as I say, some of the highlights regarding all the positive stuff they've done, some of the challenges they've faced, and perhaps a look at the year ahead, what the future holds.
Thank you, Naj. Louise, welcome.
Thank you. I'll be very brief then. As Naj has just indicated, we have taken on a lot of additional work this year. We've been particularly driving forwards work with our international medical graduates and trying to make them feel a real part of the team and the culture in George Eliot. We're also working with our SAS doctors, and we've taken on some responsibilities for the physician associates. I think the biggest piece of work we've taken on, and Catherine will know all about this one, is appraisal, revalidation and job planning work. We've been doing that since August last year. I think we're making some really good progress, but there is more work to do, but it will require further resource. We've been quite lucky that we've been able to succession plan internally, and we've been working in collaboration with multiple colleagues around the trust and trying to innovate as we go along, particularly with virtual reality, looking for new sources of income, particularly with our learners, and increasing their placements. As we all know, the NHS workforce plan has now given us further challenges for the years ahead now. We've been very successful and increased our foundation trainee posts through successful bids. We've also established further roles within the team for our physician associate tutor, who started today, and some additional CAF posts. So we really are becoming a very MDT team, which is nice to see. Challenges ahead then, so doubling of medical students. We already have significant placement pressures. It's also going to impact on our supervision of those learners and increase the workload for our educators. I think that probably is a brief summary. Hopefully I can just answer any further questions. Thank you.
No, thank you, Louise. And Louise, just for you and your team, you do an outstanding job for us as a trust, and we really do punch beyond our weight in terms of education, and that's because of your and your team's leadership. So thank you very much. Questions and perspectives to Louise and Naj. Glenn?
So echo what Russell just said. Thank you, Louise, for presenting this to us. Obviously, with the workforce plan, there will be a call for increasing the numbers, and I think you just described some of the challenges there. Do you think we will be in a position where we could offer more student placements this year?
So we will have to provide some additional student placements from September anyway, because the cohort has already increased. We've got plans to work around what we're going to do with that and what that will look like. I think the biggest risk for us is lack of teaching space and needing more flexibility in the way medical student placements work.
Okay, thanks for that. Russell, if I just may, I think one of the issues that we'll probably touch on next month when we look at the workforce plan in more detail is that issue of At the moment, there doesn't appear to be any capital alongside it to increase physical capacity. But we just need to watch that space, because I imagine that might be an opportunity at some point.
Yeah, build another story on top of the building, Louise. Catherine, your hand went down, so I assume that was covered off. Louise, take back at the board's thanks to all of your colleagues. Keep up the great work. A wealth of opportunity coming our way, and look forward to further updates going forward. But you did mention medical appraisal and revalidation, and the annual report for that is next. So, Catherine, over to you.
Thank you very much. Well, this is the last time I'm going to present this report before handing it over to the next medical director. Yeah, the report can be taken as read, but I guess the things that I'd highlight is medical appraisal. In the way that we have to capture this is whether you've had an appraisal between the 1st of April and the 31st of March. So new people joining the trust in February, if they haven't had an appraisal before, they get counted against us. So actually the figures are a bit lower in this than we're currently reporting for medical appraisal rate, as doctors who don't often get a lot of praise have got the highest appraisal rates of any staff group in the organisation. So for this report, 83% of our doctors had an appraisal in that year. But currently we're reporting, if we look at the way we report on the last 12 months, 93% of our doctors have had medical appraisals. I would like to thank Louise's team. I don't know if she's still listening, because they have taken over. Yes, she's still there, have taken over the support function for appraisal and revalidation. And that's really helping support drive up the appraisal rate, really getting to grips with getting ahead of the reminders for people to have their appraisal. The bit that the board needs to do here, as you can see in the appendix, we have to submit our self-assessment to NHS England every year in respect of medical appraisal and revalidation. So I'm asking the board to approve that so that you can sign that on our behalf, Russell. And then finally, just to say that we have been increasing the way that we are looking at the appraisal rate for physicians associates and dentists in the organisation, and really strengthening that in addition. And whilst that doesn't really form the basis of what we have to report from a statutory function, it is important for these two staff groups as well. Thank you.
Thank you, Catherine. So we'll come back to your approval in a second, but any questions or perspectives initially to Catherine? Okay, thank you. Thanks for all our doctors with all the background work to drive up those revalidation numbers, and the relevant approvals Catherine's seeking. If you're not happy to provide that, could you please raise a digital hand? Okay, so delegated approval given. Thank you, Catherine. So we'll move on then to the subcommittee chairs update, and the first of the quacks from the 23rd of May and the verbal update from the 27th of June. Sarah. Sarah, if you're talking to me, I can't hear you. Oh, Rosie.
Hello, I think Sarah went poorly and had to leave the meeting. I got a message.
Okay, apologies. I didn't get that message, so apologies for that. So I'll take the 23rd of May report as read. Any questions on that report? Okay, then we'll move on to the Foundation Group Strategy Committee of the 23rd of May, which I'll take as read. Any questions the colleagues would like to ask, or Julie, that you would like to add?
I've got nothing to add. We've spoken about Worcester. I would commend the group improvement week and all the hard work that was put into that. It was very successful.
Yes, no, absolutely. Well said, Julie. So any questions on that? Please raise the digital hand. Okay, and then we'll move on to the Audit Committee, the Extraordinary Audit Committee of the 19th of June. Julie, I'll have you down on this.
Yes, it was my final chairing of this particular meeting. Take the note as read. I'd like to thank everybody that was involved in the production of the statements that got us to this point. Positive external audits for both financial statements and value for money statements.
Okay, thank you, Julie, and thank you, Simone, for taking up the weighty burden of becoming chair of audit committee. I know you're doing a great job, and I know you really appreciate the way Julie's helped you in the handover period. Any questions? And then we've got the QUAC of the 23rd of May, which we've just talked about. Any questions on that? So I think, colleagues, we're on to any other business. So any other business from members of the board before I go to questions from the public? Okay, and so any questions from friends, from members of the public? If you'd care to raise a digital hand, or Sarah, have we had any presented to us?
We've had two submitted. So the first one was from Natalie Mills, the Patient Forum Chair. So Natalie says that the policy exchange report that came out last week suggests that there is a hidden waiting list because of poor interface between GPs and hospitals. Is this an issue George Eliot recognises for its patients? If so, what work and actions are being put in place to improve this? I think Naj is going to answer this one. Thank you.
Naj.
Thank you. Great question, Natalie. So short answer, no, nothing that we recognise. I'll just elaborate on that. The report actually, as you know, Natalie, talks about poor interface between GPs and hospitals. And I know we've been doing, and particularly Catherine has been leading a lot of work and developing relationships between primary and secondary care over the last few years. We have lots of really good conversations, various forums, clinical professional partnership meetings. We have a clinical opportunities group meetings, and this has never come up as an issue, certainly in those areas. And secondly, we're also part of the Back to Health pathway, and you may have noted in Glenn's report earlier on a reference to volunteers calling ENT patients. So this is part of what's called Waiting Well, where our invaluable volunteers like yourself and David Carr, I see on the call, help us out in contacting patients. And one of the ways in doing that is phone calls to patients who are on waiting lists, just to see how they're on, how they're getting on, any issues they have, any risks. It reduces DNAs and cancellation rates, picks up any sort of safety issues, and keeps them in the loop. So again, coming back to the question itself, not that we're aware of, we don't think there is an issue here at George Eliot.
Okay, thank you, naturally comprehensive. And the second question, Sarah?
Thank you. So this one was from David Carr, the Deputy Chair for Patient Forum. He says that it's wonderful news about the hospital getting extra beds for surgery and a reduction in waiting times that should follow, and the expansion of the community diagnostic centre, again to improve the service to patients. Where are all the extra patients and carers going to park their cars, as it's already a problem for visitors? So Robin's going to answer this one. Thank you.
Robin.
Yes, thank you, Chair, and thank you for David for the question. Obviously, the new wards and the expansion of the CDC are additional spaces on the site and for clinical care. The two new ward areas, we've already got the patients that we will be treating through those. We already have those patients on site, and you'll remember I've spoken previously about the bed numbers that we expanded to over the winter period, where we reached 365 patients on the site, which is the same as the equivalent number of beds that we will have with the two new ward areas. So we are already seeing that footfall through the site. So I'm not anticipating a huge burden, therefore additional burden on our car parking from that facility. However, the CDC, that again is it's twofold there with car parking. One part of this is that as part of our conditions for getting agreement to host a community diagnostic centre on site was that they have dedicated parking facility, and there is a plan to provide 21 spaces for the CDC dedicated on the car park adjacent to the CDC. That won't happen until we've done further development, where we've got plans to develop some smaller spaces around the site to re-provide that same number of car parking spaces. So there'll be a net zero impact to that, but it's a really important part of that CDC agreement that was part of the terms and conditions of our development. The other part of the CDC we should remember is that the clinical activity going through there will be predominantly one-stop clinic activity, and that will in essence reduce the burden on car parking across our sites, because at the moment patients are coming in to have their initial consultation with a patient, so the one visit, they have a second visit to come and have the diagnostics, they have a third visit to the site to then come and get the test results and the results back from the consultants or the clinicians. So where the patients currently are doing 3 visits to the site, the process and the pathways we're looking to put into the CDC will mean that patients do 1 visit to the site. So therefore a substantial decrease in the burden on our car parking facilities. But we recognise that there is and has been a long-standing issue around car parking and capacity on site. So it is a focused piece of work that certainly Catherine has taken a mantle on in her new role, but again, in line with myself and Kirsty Webb as our head of estates, doing a detailed piece of work on how we can further develop car parking across the site for the benefit of our staff and patients.
Okay, great. Thank you. Very comprehensive. I need to watch the time a little bit as we've got the AGM. Other questions from members of the public? Keith, very impressed by your board behind you, Keith. It looks as though you're incredibly busy in your day-to-day life. But what question would you like to ask us?
Just a couple of observations, really. You've got a lot of ward refurbishments and also a couple of new wards being built. Have they got the same eco solar panels, energy efficient windows? I'm particularly keen on things like windows, because when you refurbish areas and build new, it's those sort of embedded stuff that actually mean it doesn't capture sunlight in sunny days and lose heat in the winter. So I'm quite keen that we embed that in all your redevelopment of the site. And going back onto the parking issue, we have got the number 20 bus now servicing the hospital, and we really are not pushing enough. People can go, many people free of charge if they've got the bus pass to the hospital. And the more we get people to do that, the more we can get the bus service increased to every 15 minutes rather than every half hour. So that'd be a win-win. And finally, can I mention when my wife was last up at the hospital, there's lots of troubles with parking on pavements. As you go up from College Street, up from the town and go towards the entrance, there's a continuous battle sometimes to actually go on pavements along there. Thank you, Chair.
Thank you, Keith, and all points well made. In terms of the issue of the new ward development and the sustainability of those, Jenny, do you want to come back to those specifics next month, just so we can record them in the minutes, so you can give a comprehensive answer?
Yeah, happy to do so, and I'll probably do that in collaboration with Kirsty and Robin on that, from the development around the estate, and just in terms of the bus promotion, we are aware of that opportunity and we are promoting that, and we'll continue to do so. So just wanted to pick that one up.
Yeah, no, super, thank you. I can't see any other hands raised by members of the public. I'd just like to put on record again my thanks for everyone for their hard work. The year is starting off with its normal challenges, but I'm absolutely confident under our new MD those challenges will find solutions over time. Can I suggest we have a 5-minute comfort break, get back together again at 20:03, and for members of the public, I hope to see you at the AGM at 4:30. So see you at 3:20 for the confidential board colleagues. Take care.